Good evening, everyone. I am Dr. Abhijit Trailokya, heading the Medical Department of Alchem Laboratories. Welcome you for international and national expert program titled Dapanam Conclave. So today's topic of discussion is SGLT2 inhibitor cardio-renal benefits and beyond. Focus on Dapagliflozin. For today's discussion, we have international faculty with us, Professor Thomas Zelniker. Is a cardiologist at Medical University of Vienna General Hospital, Austria. Along with Professor Zelniker, we have Indian moderator, Dr. Behram Pardiwala, consultant doctor from South Mumbai, and along with him we have a national faculty, Dr. Surya Narayan with us, and Dr. Arindam Pandey and Dr. C.M. Batra. So let me take you through the agenda. So we'll start with the introduction and opening remarks for the panelists, and then Dr. Behram Pardiwala will set the context for the entire meeting, followed by the discussion on SGLT2 inhibitor, the cardio-renal benefits and beyond by Dr. Thomas Zelniker. We will go for case discussion. The first case will be discussed by Dr. K.M. Surya Narayan, and then second case discussion will be from Dr. Arindam Pandey. Followed by question and answers. We'll take few questions from audience, and then discussion along with international speaker and the panelists. We will end the session with closing remarks and vote of thanks from Mr. Pasha, is heading the metabolic division of Alchem Laboratories. So with this, let me take an honor to introduce Professor Thomas Zelniker. He's a cardiologist at Medical University of Vienna General Hospital, Austria. Associated editor Frontiers Cardiovascular Medicine 2021, guest editor special issue of Journal of Clinical Medicine on current practice and future perspective in diabetic cardiomyopathy, ad hoc reviewer of Lancet Diabetes and Endocrinology, Circulation, JACC, EHC, and many more. Received many honors and award. I would like to read few of them. Paul Danny White International Scholar Award, HA 2020, Best Poster Award, Australian Society of Cardiology 2020, Julius Club, then German Cardiac Society, and many more. So research interest in interplay of obesity, metabolic health, and cardiovascular disease, heart failure, prevention of cardiovascular disease, biomarkers, and the genetics of cardiovascular disease. With this, I would like to welcome Professor Thomas Zelniker for this program. We have Dr. Behram Pardiwala with us, a consultant in medicine at Wockhardt Hospital, South Mumbai, regional faculty of International Diabetic Federation course in diabetes, life member Association of Physicians of India, founder life member Indian Society of Critical Care, and then a committee member of Indian Burn Research Society. Awarded again many medals under his name. Then he has written numerous national and international publications. He has also invited to deliver the lectures at various medical association meetings and the medical college. He has been involved in numerous clinical trials and the lead investigation in various trials. So welcome, sir, for this program. Dr. K.M. Satyanarayan, sir, is a consultant endocrinologist from Bangalore, senior professor at Department of Endocrinology, MS Ramaiah Medical College, Bangalore. Recipient of President Award, Vishishta Seva Medal, ex-Director General Medical Services, Indian Navy, past physician to President of India, then President Karnataka and President of Karnataka Endocrine Society. So welcome Dr. Surya Narayan for this program. And we have Dr. Arindam Pandey. He's a senior consultant international cardiologist, currently working as senior consultant international cardiologist from Department of Cardiology, Medica Super Specialty Hospital, Calcutta, international proctor for CRT implantation, more than 50 publications in reputed national and international peer-reviewed journal, contributed more than 10 chapters in different cardiology textbook, and a peer reviewer of many index medical journals, including Indian Heart Journal and BMJ. principal investigator and co-investigator of many trials and registries like Revolution Study. Sir was the participated. So with this, I welcome all the panelists for this program. And now I would like to hand over the session to Dr. Behram Padiwala. Over to you, sir.
Thank you, Abhijit. Thank you very much. Uh, can you let me share my screen, please?
Yes, sir.
I hope that you can see the screen.
Sir, you can make it in
Yes.
full screen mode. Yes,
Yes.
visible.
Thank you. So I just wanted to have a very brief introduction on the usage of SGLT2 inhibitors in the Indian practice. We know that this is the ominous octet, and we know where most of the drugs act and how it causes hypoglycemia. If you look at the various cardiovascular outcome trials, and you look at the DP4 and SGLT2 inhibitors, you will find that a lot of them have passed by from 2013 till almost 2020, where you have the Dapagliflozin, the Emperor Reduce, and the Declatimine have all taken part. And all of them have shown that SGLT2 inhibitors are fantastic drugs. What is the rationale behind the use of SGLT2 inhibitors to manage the hypoglycemia and type 2 diabetes? And we know that there are a lot of them. They are novel, uniquely insulin independent. They have glycemic efficacy as anticipated, even with worsening beta cell failure, and they have a potential to complement any available anti-hypoglycemic agent. Intrinsically, because of the mode of action, very low risk of hypoglycemia. And not only that, they give you negative energy balance and the potential for reduction in blood pressure. The mechanisms are different. Perhaps you could say osmotic diuresis, metabolism, sodium, and I'm sure Professor Thomas would possibly be touching on this. And this is, of course, I leave for Professor Arinandam Pandey regarding the cardiac function, and for Professor Suryanarayan talking about insulin, oxide resistance, and glucagon. Of course, we have fantastic cardiovascular renal outcomes. That's why these drugs are fantastic. If you look at SGLT2 inhibitors in India, this is a present position, and the DGCI approval, etc., that we have. And if you look at the SGLT2 market in India, you'll see that the number of patients is rising exponentially from 428 in 2018 to 943. And this is the approximate share of the SGLT2 inhibitors in India. And if you look at internationally, you have the 2019 ACC/ASA guidelines on the primary prevention of cardiovascular disease, 2019 ASC guidelines on diabetes, pre-diabetes, and cardiovascular disease, where they mentioned in the ACC that you could use it for primary prevention of CVD. And in the 2000 ESC guidelines, CV benefit, and you can use it for CVD or very high CVD. So these are some of the newer guidelines which are telling us how to use these SGLT2 inhibitors. And they also now talk about first-line therapy in type 2 diabetes in the European Society of Cardiology guidelines, especially where you have a very high atherosclerotic cardiovascular disease. Lastly, KDIGO last year gave the treatment algorithm in patients with type 2 diabetes and CKD, as the second drug would be metformin and SGLT2 inhibitors combined together. So where are we now? The capture cross-sectional study showed that even if you look at the differences with age and gender, etc., people living with type 2 diabetes have established cardiovascular disease. And only 2 out of 10 are being treated with a glucose-lowering drug. The benefit. That is a crying shame. That is something which we need to change. That is something that you need to look into. Because if only 1/5 of the patients are taking treatment for a proven cardiovascular benefit. When 33% of these patients have established CVD and another 33% have latent CVD, it's criminal not to use any of these drugs. Therefore, I think the use of SGLT2 inhibitors should increase, and none of the SGLT inhibitors, unfortunately, is being used more than 10% of the population. None of them. And therefore, the challenges in the practice is the use of SGLT2 inhibitors in clinical practice is to make clinical practitioners implement SGLT2 inhibitors in routine clinical practice. Of course, a high cost of SGLT2 inhibitors can be a barrier to implementing the treatment. But now with Dapa going off patent, we've had a plethora of Indian companies which make Dapagliflozin. And that makes it all the more reason that we make the clinical practitioners, especially the primary care physician, implement this more often. So ladies and gentlemen, from 2014 to 2021, you can see the baby of SGLT2 inhibition working. Thank you very much. I'll stop sharing my screen, and Professor Thomas, it's over to you. Thank you.
So good afternoon. Thank you so much for having me here. It's truly a great honor, and I'm very humbled to join you here in India and review the benefits of SGLT2 inhibitors across the cardio-renal metabolic disease spectrum. And I agree with Dr. Padwala that these are fantastic drugs that have revolutionized the management of treatment of patients with diabetes, chronic kidney disease, and heart failure. And also brought together a lot of different specialties, cardiologists, endocrinologists, nephrologists, and most importantly, primary care physicians. So these are my conflicts of interest. This lecture is kindly sponsored by Alchem Metabolics, but I'm speaking freely and these are my slides. Now, obviously it's awkward to speak about a pandemic amidst a huge coronavirus pandemic, but we need to acknowledge that more than 460 million adults are currently living with diabetes. So diabetes is one of the fastest growing health challenges in the 21st century, with the number of adults living with diabetes having more than tripled over the past 20 years. You can see on the right side that the projections are steep. There's a steep increase expected until 2045, with more than 700 million people living with diabetes. And the highest increase is particularly in patients who are older than 65 years. This is another additional challenge for our growing older and aging population. And patients with diabetes have a great burden. And also, this is associated with a huge burden on our health economic costs. Diabetes is the #1 cause of blindness in working age adults. It's the #1 cause of end-stage renal disease and requiring dialysis. It's the #1 cause of non-traumatic lower extremity amputations. And we all know that patients with diabetes have a high risk to develop coronary artery disease and suffer from myocardial infarction. Now, another link is well known more than 50 years, but has been acknowledged only recently. Patients with diabetes have an increased risk to develop heart failure. Now, these are data from the Framingham cohort published in 1974, showing that patients with diabetes have a 2-fold to 5-fold increased risk of developing heart failure compared with non-diabetic patients. And these data have been reconfirmed in more contemporary study settings. Now, thanks to the advent of statins and optimized controlled cardiovascular therapy, we have observed a significant reduction of myocardial infarction in patients with diabetes over the last 25 years. And these are interesting data from the Swedish National Diabetes Register, suggesting the important role of good control of cardiovascular risk factors to reduce the atherosclerotic risk. Now, patients who had optimized controlled blood pressure, LDL cholesterol, HbA1c, smoking, and albuminuria had similar risk of having a myocardial infarction compared with non-diabetes patients. However, patients, even those with well-controlled cardiovascular risk factors, remained at increased risk of developing heart failure. Now, we all know that patients with diabetes also have a high risk of developing atrial fibrillation. And conversely, patients who have atrial fibrillation who have diabetes have higher risk of serious adverse events and worse outcomes. Now, atrial fibrillation is a disease that significantly increases with older age. And there's several other non-modifiable risk factors as genetics and height and a family history. But you can see on the right side, we see several modifiable, reversible risk factors that we can address to reduce and prevent atrial fibrillation. And all these modifiable risk factors, they come from a spectrum of cardio-renal metabolic disease. So patients who have diabetes, obesity, heart failure, and chronic kidney disease all have a high risk of atrial structural and electrical remodeling and are therefore at increased risk of atrial fibrillation. Now, meanwhile, 2 years ago, the European Society of Cardiology suggested a very appealing approach called the ABC approach, the atrial fibrillation better care approach. A standing for anticoagulation and avoiding stroke. So patients with diabetes have at least 1 point in the CHA2DS2-VASc score and require oral anticoagulation. B standing for better symptom management, referring to heart rate and heart rhythm control. And C, cardiovascular and comorbidity optimization, which is the topic of this lecture. We all associate atrial fibrillation with an increased risk of thromboembolic events and death. But we need to acknowledge that other adverse events are even more higher. The NOAC trials showed that the annual event rate within the warfarin arm was about 1.5% per year. But these patients have high risk of hospitalizations of 10 to 40% per year. And those are to a significant impact due to heart failure. So how come that SGLT2 inhibitors have revolutionized the management of patients with cardio-renal metabolic disease? In 1835, the chemist Christian Peterson identified the first SGLT2 inhibitor. It was a non-selective SGLT2 inhibitor called Florizin, and he extracted it from the root bark apple tree. And it took about 50 years that Joseph Mering noticed the glucosuric effect of SGLT2 inhibitors in his manuscript about artificial diabetes. And then another 80 years until the US chemist Richard Crane postulated that reabsorption of glucose is dependent on sodium. So SGLT2 inhibitors inhibit the SGLT2 transporter in the proximal tubule of the kidney, resulting in glucosuria and natriuresis. And in 2015, the first trial was published, the EMPEREG outcome trial, that proved cardiovascular benefit in patients with diabetes. So who gave thanks for these? I think most of these gratitude should be addressed to the US FDA, to the Food and Drugs Administration, that changed the regulatory obligations for new diabetes medications. In 2008, due to initial concerns about the cardiovascular safety of rosiglitazone, the FDA mandated a two-step approval process. In the first step, pharmaceutical companies have to show effective HbA1c reduction and exclude excess risk. This means basically that that pharmaceutical companies have to rule out an excess of 80% risk in cardiovascular events, which translate to design a trial for this in 122 events if you wish to have 90% power. So this is actually the number of events that we have seen in the UK PDS trial published after 10 years of follow-up. And this is followed by a second step to rule out definitive excess risk of 30%. And just to show non-inferiority with this margin of 30%, requires 611 events. So this changed the landscape of clinical trials. And on the right side, you can see the number of patients that were with diabetes randomized and enrolled in clinical randomized controlled trials. So in 2008, there were approximately 30,000 patients enrolled in clinical trials. And Holman projected that this number would be 200,000 in 2020. Now, we look at 600,000 patients enrolled in randomized clinical trials who have diabetes. And so we have learned a lot of new information. Sorry. The largest cardiovascular outcome trial published to date was the Dapagliflozin trial that studied the efficacy and safety of Dapagliflozin versus placebo in patients with type 2 diabetes who either had established atherosclerotic cardiovascular disease or multiple risk factors for cardiovascular disease. So a primary and secondary prevention patient population. Indeed, the majority of patients had multiple risk factors and did not have established cardiovascular disease. Now, the Dapagliflozin trial had a dual primary endpoint, and Dapagliflozin versus placebo significantly reduced the relative risk of a composite outcome, cardiovascular death and hospitalization of heart failure by 17%. With respect to the composite outcome of myocardial infarction, ischemic stroke, and cardiovascular death, there was Dapagliflozin was non-inferior, but did not prove superiority. Now, meanwhile, we have 5 cardiovascular outcomes trials published in patients with diabetes. We have EMPA-REG outcome with empagliflozin. We have Dapagliflozin with Dapagliflozin. We have the CANVAS program with canagliflozin, with ertugliflozin, with Vertosivi, and we have sotagliflozin for SCORD. And now pooling all these effects showed that the effect on MACE, on atherosclerotic events, MACE stands for major adverse cardiovascular events. It's the composite of MI, stroke, and CV death. Well, the effect is modest, and there is obviously some heterogeneity across these trials. But SGLT2 inhibitors robustly reduce hospitalization for heart failure and progression of kidney disease. Now, these trials were not dedicated heart failure outcome trials. So the next question from these findings was, first, do SGLT2 inhibitors also reduce the risk of heart failure in patients who have established heart failure? So does it only prevent heart failure, or does it also treat heart failure? And the second important question was, obviously, does it work also in patients who do not have diabetes? And DAPA-HF was the first dedicated heart failure outcome trial that studied the effect of Dapagliflozin in patients with heart failure and reduced ejection fraction. And after a median follow-up of 18 months, Dapagliflozin significantly reduced the relative risk of worsening heart failure and cardiovascular death by 26%, resulting in an absolute risk reduction of 5% after 2 years. This translates into a number needed to treat of 20 patients over 2 years. And very reassuringly, the effect of Dapagliflozin on the primary endpoint was similar in the individual components, worsening heart failure and cardiovascular death. So it was a 30% relative risk reduction of heart failure and a nearly 20% relative risk reduction for cardiovascular death. Importantly, these risk reductions, they are very robust, but they are also very consistent across all studied patient populations. There is a nearly 30% relative risk reduction in patients with type 2 diabetes. In the panel, you can see this result in red, the red diamond on top. The effect is similar in patients with chronic kidney disease, and it's similar in HFrEF. So how can we communicate these fantastic results to our patients? Now, Muthu Vaduganathan has showed a very interesting, very important study by using other clinical trials, data sets, and performing a indirect comparison. He published recently in Lancet that patients who have a comprehensive therapy benefit substantially compared to patients who have a conventional therapy. So patients who are treated with ARNIs, Entresto, beta blockers, MRIs, and SGLT2 inhibitors benefit compared to patients who have only ACE inhibition and beta blockers. They live longer, they have less admissions for heart failure. And for example, a 55-year-old patient treated with conventional therapy, just with ACE inhibition and beta blockers, has a projected mean event-free survival time of 6.4 years. However, a patient with comprehensively treated with ARNIs, beta blockers, MRAs, and SGLT2 inhibitors has a projected event-free survival of 14.7 years. So this patient lives for 8.3 years longer without hospitalization for heart failure or cardiovascular death. Now, the same applies for that was interested for have heart failure, was also interested for progression of chronic kidney disease. Declared-TIMI 58 enrolled patients with preserved eGFR. So patients who were enrolled in this trial had to have a creatinine clearance above 60. And there was a robust relative risk reduction of the composite of worsening eGFR, renal death, and end-stage renal disease. The DAPA-CKD trial enrolled patients with and without diabetes and showed a very similar event rate, a very similar magnitude of effect. Obviously, the event rate was much higher because patients with lower eGFR had higher event rates. So the SGLT2 inhibitors prevent kidney events from the very early stages to advanced stages of CKD. Now, in a meta-analysis pooling the first 3 cardiovascular outcome trials, we saw that the effect of SGLT2 inhibitors on the progression of kidney disease, well, it was robust across all tested kidney subgroups. Patients with an eGFR below 60, that's in the top panel, and the blue diamond shows the pooled effect, was significantly reduced in these patients, similar in patients with 60 to 90, a 45% reduction. And in patients with an eGFR above 90, the effect size was even 55% relative risk reduction. So we saw that the magnitude of the relative risk reduction was even higher in patients with improved and preserved kidney function, suggesting that there is also an effect in preventing hyperfiltration in patients with renal disease. So SGLT2 inhibitors modify several risk factors that are associated with an increased risk for atrial fibrillation. They're good for diabetes, they're good for chronic kidney disease, and they're good for heart failure. But they also have beneficial effects in reducing weight, they reduce blood pressure in patients who are hypertensive, and they have shown to have anti-inflammatory effects to reduce inflammation and oxidative stress. So in a post-hoc study from the DECLARE-TIMI 58 trial, we studied the effect of dapagliflozin on the incidence of atrial fibrillation and atrial flutter. Now, this was a post-hoc study. We identified the event by searching the safety database. And here you can see the primary result. Dapagliflozin reduced the relative risk of atrial fibrillation and atrial flutter by 19%. And it did not only reduce the first event, there was also a significant reduction of the total number of events. So in total, 432 events occurred in 325 placebo-treated patients, and 337 events occurred in 264 dapagliflozin-treated patients, resulting in an incidence rate ratio of 0.77 with a 95% confidence interval of 0.64 to 0.92. And looking at important subgroups, we did not see any effect modification in patients with known atrial fibrillation versus those who did not have atrial fibrillation at baseline. So these data suggest that dapagliflozin reduces new onset atrial fibrillation, but also worsening of atrial fibrillation. There was a consistent treatment effect in patients with atherosclerotic cardiovascular disease and those with multiple risk factors. And also, there was no effect modifications by presence of heart failure. There was also no effect modification by age, by sex, eGFR, blood pressure, and any other variable associated with the CHA2DS2-VASc score. Now, we did also perform several sensitivity analyses. Now, looking only at serious adverse events, there was a consistent treatment effect, and also looking at patients who were hospitalized for atrial fibrillation and atrial flutter. We all know that atrial fibrillation can be an alias for hospitalization for heart failure. So we also excluded patients who had an event 14 days before or 14 days after atrial fibrillation, as well as we excluded all patients who ever experienced hospitalization for heart failure. And also here we see a consistent treatment effect. Now, there are several limitations that we need to acknowledge. For one, these are post hoc analyses. The ECGs were not systematically collected, and atrial fibrillation was not a pre-specified outcome. It was determined by local investigators and reported by them. But we do assume that these limitations occur to both as this was a randomized controlled trial, that both treatment arms should be affected the same way. Now, in a meta-analysis of all SGLT2 inhibitors, there was a very similar pattern. Now, only the Clarity 58 and the Credence trial reported the results for atrial fibrillation, but many of these trials also report atrial fibrillation in the safety outcomes and are published in clinicaltrials.gov. And Pandayat's colleagues meta-analyzed all SGLT2 inhibitors, SGLT2 inhibitor trials, including the major cardiovascular outcome trials, and also indicated that there was a 25% relative risk reduction with SGLT2 inhibitors in patients with diabetes on the risk of atrial fibrillation. So how does this compare to GLP-1 receptor agonists? Now, GLP-1 receptor agonists have shown protective effects in patients with diabetes as well, in particular atherosclerotic events. But GLP-1 receptor agonists reduce blood pressure, but also can increase the heart rate. So this is a meta-analysis of randomized controlled trials that included patients with diabetes that compared the GLP-1 receptor agonist with placebo or any other non-GLP-1 receptor agonist drug. And on the left side, you can see the overall treatment effect, also stratified by the individual GLP-1 receptor agonists. We know that there is substantial heterogeneity between these GLP-1 receptor agonists. And there was no effect, there was no increase, but also no significant decrease for atrial fibrillation. And on the right side, you can see the comparator. So also looking only as placebo as the comparator, there was no significant risk reduction with GLP-1 receptor agonists. We know that patients with heart failure and reduced ejection fraction may benefit in different ways when they have atrial fibrillation. Now, obviously, ivabradine cannot be used in patients with atrial fibrillation because it addresses the funny chance of the sinus nodes. We need sinus rhythm for this drug. But also for beta blockers, we have data suggesting that there might be some effect modifications between patients with atrial fibrillation and without. Now, this is an individual participant level meta-analysis of the beta blocker trials, indicating that patients without atrial fibrillation benefit from all-cause mortality reduction, but not in patients with atrial fibrillation. The right panel shows patients with AFib, and there is no significant risk reduction. There's no harm, but there's also appears to be no benefit. We know that patients who have cardiac resynchronization therapy may not benefit in patients with atrial fibrillation. And most recently, in the GALACTIC-HF trial, omecamtiv indicated there was a significant effect modification in patients with AFib. So the Dapagliflozin trialists studied the effect of dapagliflozin in patients with atrial fibrillation, and there was no effect modification. Reassuringly, there is a consistent treatment effect across all subgroups, looking at patients who have any AF, those who have paroxysmal or persistent AF, or those who had documented AF on the ECG at baseline. There was no significant reduction in new onset atrial fibrillation. However, there are a couple of differences that have to be highlighted. For one, the trial was substantially shorter. The median duration follow-up in DAPA-HF was 18 months compared to 4.2 years in the Declare TIMI-58 trial. And these were patients, there were substantially less events, right? There were only 120 events compared to approximately 400 events in the Declare TIMI-58 trial. So what is expecting us in the future? We have seen now that SGLT2 inhibitors have changed the guidelines for patients with diabetes, chronic kidney disease, and heart failure. We are expecting the trial results for patients with HFpEF. The DELIVER trial is expected to be presented this year. And dapagliflozin is also studied in several other trials. We are expecting the DAPA-ACT trial that studies the effect of dapagliflozin in patients with acute decompensated heart failure, which will answer the question, how early can we start with treatment with SGLT2 inhibitors? Then we have DAPA-TAVI, a Spanish study. We know that patients who get TAVI for severe aortic stenosis, they benefit, but have a high risk of rehospitalization within the first year. We will see if dapagliflozin can reduce the risk of hospitalization in these patients. And we have DAPA-HD, which will also study the effect of dapagliflozin in patients on hemodialysis. This is a small mechanistical study that will determine if patients who have loss of kidney function still experience any cardiac remodeling. So let me summarize. SGLT2 inhibitors have favorable metabolic effects in type 2 diabetes. They reduce HbA1c, they reduce blood pressure, they reduce body weight. They have moderate effects on atherosclerotic events, but very robust effects on heart failure and renal outcomes. And SGLT2 inhibitors reduce heart failure and death in patients with HFrEF, irrespective of if they have diabetes or not. And similarly, they reduce the risk of progression of chronic kidney disease, irrespective of the presence or absence of diabetes. So in conclusion, SGLT2 inhibitors have truly revolutionized the management of diabetes, heart failure, and chronic kidney disease. So allow me to finish on a somewhat humoristic note. An apple a day, or more precisely, a derivative isolated from the root bark of apple trees, keeps the doctor or MI, HF, and CKD away. Thank you very much.
Thank you, Professor Zenica. That was a beautiful exposition on the state of the SGLT2 inhibitors in today's world. Truly a beautiful exposition. And as you very truly said, that no wonder it's been adopted by endocrinologists, by cardiologists, and even by nephrologists now. We'll take the questions and answers at the end of the two case presentations, if you don't mind, Professor Thomas.
Absolutely.
Fine. Can I ask Professor Suryanarayanan to start with the first case, sir?
Thank you, sir. Thank you, Dr. Behram. Shall I share my slides? Yeah. Just trying to make it full screen. taking some time. Yeah. A very good evening to all. Thank you, Dr. Thomas, for that very lucid and excellent talk on particular the SGLT inhibitors in the context of the heart and the kidneys, and the new information which you are given in regarding to atrial fibrillation. It was all new to me as an endocrinologist, because I know this, as Dr. Behram told initially, the SGLT inhibitors, we thought it stays with only the endocrinologist, but now we see the cardiologist, nephrologist, so that we have the pleasure of talking or interacting with all these specialities, because the drug has become common and uniting all of us. That's what I find now. The SGLT inhibitors has brought us all to the common form. My task is to give a case scenario and how we are going to treat this patient, which we see commonly in our clinical practice. As you know, Dr. Thomas, India is one of the country where we have a lot of diabetic patients, almost now as per the latest figure, 65 to 70 million. And the prevalence rate, which was quite low in the rural population, is increasing like what happened in the urban population, maybe because of the change in the lifestyle, better food availability, as well as more machinization, where people are not walking, they're using more of two-wheelers, cars for the movement, even going to the fields and farms. Now they are using two-wheelers. They are not using any more walking, which I used to see earlier when I was young. So that has changed the scenario here. And as you see, our diabetic OPD number of patients keep on increasing. And we are seeing more young diabetics in the age of 20 years, 25 years, 30 years in Bangalore, which is in India. Young people, particularly people who are with the software, who sit all the time at the front of the computer and have less time for the physical activity. And with the COVID situation in India, the numbers has increased because of work from home culture. Where people are not exercising. That's another problem. So I got a patient, which we see normally in our outpatient practice, a 45 years old lady who has got a history of type 2 diabetes for the last 5 years. So she has got the onset of diabetes at the age of 40. In India, normally we see, as I said, diabetes at a much younger age than in the Western countries, almost a decade earlier. That's what is happening. And even the cardiovascular diseases are 1 decade earlier here than when you compare to your population. So this lady, like any other diabetic patient, is on 2 grams of metformin every day. Normally we give up to 2 grams. We can give up to 2.4 grams per day. And as we know, the tolerability of metformin, occasionally, a lot of patients have gastritis and gastric intolerance. But this lady is on 2 grams, glimepiride 1 milligram only once a day, along with lifestyle modifications, means walking every day, some sort of physical activity, dietary modification, which has been advised by her doctor. In addition to diabetes, this lady has hypertension for the last 2 years, and she's already on telmisartan 40 milligrams and amlodipine 5 milligrams once a day. She's on 2 antihypertensive drugs, and she, in addition, also has dyslipidemia and already on a statin, that is the rosuvastatin, 20 milligrams per day, quite good dose. So that's what normally advised in any patient, either a moderately intensive statin therapy, and 20 milligrams is good enough for this patient, I feel, and you agree with me. And now she has come to our clinic with hyperglycemia and hypertension. And in addition to these 2 risk factors of hypertension, dyslipidemia in a patient who already has diabetes and 2 oral anti-diabetic agents, she has a family history of premature coronary artery disease. 1 brother died of MI at the age of 36 years, and a sister underwent coronary artery bypass graft at the age of 40 years. So very strong family history of coronary artery disease. So this is very important for us, but this is an additional risk factor. So to look at the weight, the BMI is 29.4 as per the Indian Asian standards. The lady is obese, pulse is 70. The blood pressure is still on the higher side, 164/98. We generally want in this diabetic patient less than 140/80 or 130/80 if you could maintain without any side effects, any other problem. HbA1c is 7.9. This young lady, 40 years, we like to have an HbA1c of less than 7. If you could achieve without any hypoglycemia, without any other much side effect, 6.5 is still better over a long period of time. So that should be our goal. Fasting blood glucose 149 should have at least between 90 to 130 and postprandial 270, which is also high. We should aim at least less than 160. We don't have a continuous glucose monitoring, time in range, which should give us more information than just one HbA1c value at the fasting and postprandial. Because time in range is also important. We know that. And when we want in this diabetic patient a time in range between 70 to 160 milligrams or 70 to 180 milligrams, at least more than 70% of the time in a day is ideal in this patient. Serum creatinine 0.9 milligrams, quite okay. Cholesterol is 223 total. LDL cholesterol is still on the higher side, 134. So this is the case scenario. So the problems, as I already brought out in this patient, one is she's hypertensive, she's got raised cholesterol, while on strict LDL, the statin treatment, the LDL is still on the higher side, the BP is on the higher side. She's got a strong family history of cardiovascular disease, and in addition, she has obesity. She has got multiple risk factors to develop a coronary cardiovascular disease, a cardiovascular event in the future. So what are the options available to us? We have got many drugs today because we have understood the pathophysiology of diabetes much better than what we earlier. And the octet, we already know the different pathophysiological mechanisms. So this patient is on two drugs. One is the metformin, which is more of an insulin sensitizer, and also it decreases hepatic glucose output. And the other is glimepiride, which increases the insulin secretion, that is insulinotropic drug. So metformin is more of a weight neutral drug. Some people do have weight reduction in their drug. Glimepiride may cause weight gain. Glimepiride may also cause hypoglycemia. It's already on two drugs, well tolerated with not effective HbA1c control or the fasting postprandial. So one option is to increase the dose of glimepiride. You know, glimepiride can be given to a maximum dose of 8 milligrams. That is the maximum recommended dose. But in our practice, we do find that more than 4 to 6 milligrams of glimepiride has not much of any great significant effect on lowering the blood glucose. In my practice, I don't usually give more than 4 milligrams of glimepiride, maybe in a single dose or 2 divided dose. So this is one option for that. Suppose we increase the dose of glimepiride, what can happen? She may increase the weight. She's already obese, and that is one disadvantage with glimepiride. And we know as over a period of time, the sulfonylureas, and glimepiride is one of the sulfonylureas, become less and less effective over a period of time. Earlier, we used to call the sulfonylurea failure or the OHA failure because, as we know, the natural history of diabetes, the beta cells undergo apoptosis. And even in a type 2 diabetic patient, the loss of beta cells is around 4 to 5% every year. So the glimepiride, we may increase, but at the cost of hypoglycemia and weight gain, and may not have really able to bring the blood glucose and the HbA1c to the target value. DPP4 inhibitor, yes, it's a good choice because DPP4 inhibitors are weight neutral. The chances of hypoglycemia is less, and one of the cardiovascular neutral drugs that do not increase, they may not have any cardiovascular benefit, but they're at least cardiovascular neutral, and it can be given once a day depending upon which drug you choose. But here the background of what the patient has got, the multiple risk factors for a cardiovascular problem, and this drug is a cardiovascular neutral. Definitely we'll be able to reduce the HbA1c, reduce the blood glucose level. But as per the current recommendations, whether it is the American Diabetic Association or any other guidelines, we have to select a drug which can be more cardioprotective and renal protective, particularly in the presence of multiple risk factors. So this is one choice, but are there any better choices? So what are their options? Some of the drugs may be expensive, like the GLP-1 receptor analogs. In India, as and today, only the injectables were available so far. Now we have got the oral semaglutide for the last 3-4 months. And but still the cost factor is quite high. And we know the side effects of the GLP-1 receptor analogs or agonists. Initially, for about 2 to 3 weeks, a lot of our patients do have GI side effects like vomiting, nausea, and abdominal discomfort, but they usually overcome with this. But cost is one of the factors. But as brought out earlier by you, they are quite drugs which have the benefit of the cardioprotection. And the SGLT2 inhibitors have the advantage like GLP-1 receptor analogs by reducing the weight to a tune of 2 to 4 kgs, and also to a certain extent bringing the blood pressure of systolic 3 to 4 and diastolic 2 to 3 millimeters. And this is the additional benefit with the SGLT2 inhibitors. And the trials which are shown, whether it's the empiric trial or the declared trial, they all show some benefit, particularly as far as heart failure is concerned. But the empiric trial showed benefit even as far as the cardiovascular death to a tune of 34%. So if somebody has got underlying cardiovascular disease or the multiple risk factors, cost is one factor when you prescribe these drugs. Ideally, this patient should be on a GLP-1 receptor analog or an SGLT inhibitors in addition to metformin, glimepiride. We may continue in the small dose what the patient is getting, or we can stop, but is one of these two drugs should be the choice in this patient. So, as I said earlier in my previous slide, the GLP-1 receptor analogs, they have definitely benefit on the weight, which I have seen in our clinical practice. Some patients lose even up to 10 to 12 kgs or 15 kgs, I have seen with liraglutide. But normally the weight gain is around 3 to 5 kgs. Even the oral semaglutide, whatever the studies have been done so far, it shows definite weight benefit. Cardiovascular protection has been shown by done with the liraglutide and oral semaglutide and injectable semaglutide. More with the injectable CV protection is definitely the leader trial with the liraglutide has shown they have some benefit on particularly the lipid lowering and a very small benefit on the PP lowering. The disadvantages, the injectable, as I said today, we have got the oral drug, so injectable may not be disadvantage because we have got the oral semaglutide and intolerance, which I spoke earlier, but it is usually lasts for 2-3 weeks, and a lot of people do get adjusted, but some of them may not be able to continue. Cost is a major factor. The SGLT inhibitors have the potential to reduce the weight like GLP receptor analogs. They have definite benefit as far as the blood pressure is concerned. Heart failure, beyond any doubt, all the SGLT inhibitors, irrespective of anyone, either Dapagliflozin, Dapagliflozin, or Empagliflozin, all of them have shown consistent benefit as far as the hospitalization due to heart failure. And both in diabetic and non-diabetic patients, the Dapagliflozin has shown. And the blood pressure reduction we see, and it is an additional benefit in all our diabetic patients where we want the blood pressure to be as well controlled as we think. And easy to administer because it can be given any time of the day, either before food or after food. But practically in our practice, we give usually in the morning. And the rare problem of euglycemic ketoacidosis may occur, but we know that euglycemic ketoacidosis can occur when you give them these drugs, particularly in patients who have acute infections or when the patient is in a critical condition. So these are not the drugs to be used in acute situations of diabetes, whether it is patients who have got severe infections, septicemia, or the patient is admitted for major surgery. So they are or patient is an alcoholic, abuse, these are the situations, or even in type 1 diabetes, they are not to be given, they are not to be prescribed. So that can be avoided because this is one which always, if you know whom to prescribe this, we can avoid. Increase LDL, maybe a slight thing. Cost, now in India, the SGLT inhibitors are more affordable than it was. So cost doesn't become an important factor today. So these are the advantages. And in this patient, I think, let me see the next slide. in this patient, our aim is not just the reduction of the HbA1c or reaching the target blood glucose control. Our aim is also to reduce the cardiovascular problems in the future because she's still young, just around 40 years. We want to prevent the coronary events, want to protect the heart, we want to protect the kidneys. With that aim, with multiple risk factors, I think the SGLT inhibitors, which are easily affordable with less adverse effects, and she's young, and if we educate her about the genital hygiene and the other precautionary things, the SGLT inhibitors should be the first drug of choice. And we can, even the GLP-1 analogs or the agonists could also be considered in this patient if she is affordable. I think that's my last slide. And thank you. You can have the discussion. Back to Dr. Behram.
Thank you, Professor Surendra. That was a beautiful patient that you gave us. I think we'll come to the discussion after Professor Arinandam Pandey's presentation. We already have a few questions lined up for all the participants. Thank you again, Professor. Can I ask Dr. Arindam Pandey to give his presentation, please?
Yes, thank you very much. So I'm probably the lone cardiologist in the whole group. So I'm really thankful for inviting me. Can someone share my case, please? Yeah. Thank you very much. So today we are actually discussing SGLT2, particularly Dapagliflozin. We have a very august gathering, and as mentioned, who actually should be credited for discovery of SGLT2 inhibitor? It is actually FDA, US FDA, because for their mandate, all the cardiovascular outcome trials were done, and from that only the fantastic benefit, the additional benefit, particularly we cardiologists look them as a very good molecule for heart failure treatment. In fact, Dapagliflozin and empagliflozin, they have become the fourth pillar of the heart failure therapy. So along with beta blocker, mineralocorticoid receptor antagonist, and ARNI or ACE inhibitor, that group, this is the fourth pillar of heart failure therapy, which has convincingly shown to reduce the mortality of heart failure patients, particularly with reduced ejection fraction. So almost all our patients, until contraindicated, we actually prescribing this molecule to them. So let us discuss my case today. My patient is a 65-year-old lady. She has a BMI of 28.5, so definitely overweight. She has a history of diabetes for last 9 years and a history of bypass surgery 10 years ago. So bypass first, followed by detection of diabetes, and on medication for last 9 years for diabetes mellitus. Currently, she is on metformin 1000 milligram twice a day, glimepiride 2 milligram once daily. Her urine albumin creatinine ratio is 39, and you know it was repeated after 6 months, which showed the urine ACR, spot ACR to be 124. So it is gradually increasing. What it indicates? It indicates the patient is suffering from some form of nephropathy. So EGFR currently is 65, though the EGFR is not very bad, it's more than 60, but still nephropathy and the proteinuria is gradually increasing. So probably in long run, the creatinine might also get elevated and the EGFR will come down. Now, she complains of glucose fluctuation. If we look at the current parameter of the lady, her fasting blood sugar is 189, postprandial blood sugar is 377 with an HbA1c of 8.9%. So here I open the forum with the question that is this medication, because we have multiple endocrinologists, renowned endocrinologists along with us, so is this medication for her blood sugar treatment is adequate, or we should be looking for something else? The opinion, please.
Well, definitely you can use an SGLT2 inhibitor, but I don't expect that the sugars will come very much down. The maximum the HbA1c will do is come down to about 8. this patient at this age, you would be aiming at between 7 and 7.5. Can I have Dr. Surinaran and Professor Thomas's opinion?
Yeah. Can I?
Please.
Yeah, this patient is already on metformin and glimepiride, and the patient has got a history of diabetes of 9 years and undergone a CABG 10 years back with poor control of high blood glucose and HbA1c 8.9. As you said, sir, the SGLT2 inhibitors alone may not be bring down the HbA1c to the desired level of say around 7 or even less than 7.5. And ideally, if the patient comes to me, one of the treatment could be still a basal insulin we may have to start. We may add an SGLT2 inhibitor for the cardiovascular benefit. So SGLT inhibitor we may add because she has already underlying coronary artery disease, and it will definitely help. But I'll start a basal insulin and add an SGLT2 inhibitor. I think that's what will be better for this patient.
Professor Thompson.
Just interrupt. Yeah, if I just interrupt. So everybody is mentioning about SGLT2 inhibitor and basal insulin. I fully agree with that. What about DPP2 inhibitor? Or to be specific, this patient is a post-ABG patient. So what about the GLP-1 analog? Nowadays, we do have GLP-1 analog, particularly the oral semaglutide is also available. Many people are afraid of taking insulin injection. So what about those? Because those are also having very strong data in particularly background of bypass surgery. I would like to have the opinion of the panelists regarding that.
I would say that in this patient, there you have three drugs which come to mind immediately. One, an SGLT2. Second, a basal insulin. Third, a GLP analog. And I have no hesitation in saying an injectable GLP-1 analog would do well in this patient. So perhaps if you could add a GLP analog and an SGLT2 inhibitor, you could achieve 7.5 and with very good results for the rest of it. Dr. Surinaran.
I strongly agree with this opinion. I don't think it's often a one versus the other. It's often the combination that will be an adequate treatment strategy. So this patient has several problems, right? She's obese. We have two great drugs that can address this with cardiovascular benefit. We have SGLT2 inhibitors and GLP-1 receptor agonists. We have a high risk of atherosclerosis, which points slightly toward GLP-1 receptor agonists. We have chronic kidney disease. We have structural disease. We have a UACR that's even, I have to say, I'm already concerned with 40, but this patient even increased to 120. So we have better data for SGLT2 inhibitors because SGLT2 inhibitors prevent progression of chronic kidney disease in a far quicker way compared with GLP-1 receptor agonists. So I think from a cardiologist perspective, which is my my profession, I think the combination of GLP-1 receptor agonists and SGLT2 inhibitors would be the perfect match for treating these patients from a cardiovascular point. And we have a very, very good relationship with our endocrinologists. So I think modern treatment of diabetes is not purely cardiology, purely endocrinology or nephrology. So it's or primary care physician. We need all these people. So usually the first thing that is also at least challenging in my practice is explaining the patient that we need to do something, because most patients come and say, well, it worked very, very well for the last 15 years. Why should I change something? So this is, I think, both of these medications are very important for this patient.
Perfect. Thank you very much, Thomas. So can we continue?
Yes, I think,
Dr. Pandey.
Yeah, so this is a fantastic opinion from the house. So as you all know, single class of molecule, they are actually unable to bring down the HbA1c beyond 1. Some of them actually can bring it down to up to 1 to 1.2%. So in this case, we are actually aiming HbA1c of around 7%. So it is always preferable to use two agents. And if we are actually using two agents, then one of the agents could be SGLT2 inhibitor. Second, I agree with my endocrinologist colleague that we can add a basal insulin, but rather, in my opinion, I would like to go with the injectable GLP-1 analog. And the data is emerging slowly, though the cardiovascular superiority is not yet proved with the oral semaglutide. Injectable semaglutide is good. We do have good amount of evidence, but probably in few days, more evidence is emerging, and after that, we will be probably in a place to add oral semaglutide as well.
You do have recommendations for GLP-1 analogs after the leader trial. So you have for Victoza, and even for dulaglutide now. You do have recommendation that you can use it. It's approved now.
Yes, I fully agree.
Yeah.
So that much from my end. I wanted to have an insight regarding the cardiovascular aspect of the SGLT2 inhibitor. So that was all from me, and we can proceed for the next case. Thank you very much.
Thank you. Thank you very much. Thank you very much, Dr. Panda. Thank you. Can we stop sharing the slides so we can go into the question and answer mode? Perfect. Thank you very much. So that was very interesting. And Professor Zandika, you would agree that in this patient, SGLT2 and GLP-1 analog would be perhaps the right choice. And we expect the HbA1c to come between 7 and 7.5. Because I would not like her to go below 7, not with that comorbid condition of a CABG, etc., and even the renal disease. So I think that would be a good positioning for her.
Absolutely.
Yeah. And so, Abhijit, any questions?
There are few questions from audience, so let me put across.
I would like. In fact, I wanted to ask one question to Professor Zelnicka. Considering that we are saying that most of the SGLT2 inhibitors act the same way, would you extrapolate all the dapagliflozin cardiovascular trials and heart failure trials specifically, and say that we could use canagliflozin and empagliflozin also in the same way? Of course, Empire's got its own trials.
Well, it's a very good question, and it's difficult to answer. I think although the results have been very similar, so I haven't been convinced that there's true heterogeneity. Even when trials didn't meet the statistical significance for some endpoints, the point estimates were very similar across all trials.
Right. So I think, but even Empire has got its own trials. The Emperor and all of these are coming in. And the Emperor with the preserved ejection fraction also is giving you good results. And of course, we are bringing down the recruitment for the kidney down to an eGFR of 20. So
can I make one comment regarding this?
Please.
SGLT2. So I personally, this is my personal opinion. I feel the reduction of heart failure hospitalization is a unique feature. It can be, seen in all the SGLT2 inhibitor, but reduction of heart cardiovascular endpoint is not uniform across the board. In fact, there has been some heterogeneity in the studies, and in fact, the latest new trial with a new SGLT2 inhibitor, R2gliflozin, that clearly shows it do not reduces heart cardiovascular endpoint, though the meta-analysis showed reduction of heart failure hospitalization.
Absolutely. So, I fully agree with you there. So if you look at it, I think Professor Thomas would agree with me. There are only two at the moment which have very good hard endpoints for cardiovascular disease: empagliflozin and dapagliflozin. Am I correct, Professor Zelnicka?
Yes, that's what we have most data for, right? But if we look at the cardiovascular death, I mean, DECLARE didn't reduce cardiovascular death, but it reduced cardiovascular death in DAPA-HF, and it was the other way around in Emperor reduced and Emperor outcome. So I feel there is a lot of similarity between these trials, and if we look at the pooled effect, it is a smaller relative risk reduction of approximately 10%. Yeah. So I think these trials were not all powered for these individual endpoints.
And that, I think
I agree that the jury is out, and we are not sure until we have hard data. Absolutely. This is my very personal opinion.
And I think what the companies are now doing is that they're trying to milk the original trials for whatever benefit that they can get, especially empagliflozin. Although empagliflozin did show a reduction in all-cause mortality, a significant reduction between, I think, 25 to 30%. So that is really something. Dr. Suryanarayan is not there.
Yeah,
I was going to. Oh, you're there, sir.
I think
okay.
they closed my video. I'm not able to open that video. I don't know. The hostess, we cannot start your video because the hostess stopped it. It is coming. To get some water.
In Rajasthan, a bride gets married to an empty chair where the sword is kept. So that is what Dr. Suryanarayan was doing.
No, I just went to get some water. Okay, fine. What was the?
So I was saying that in your patient,
yeah,
why can I not use an SGLT2 and a GLP-1?
SGLT1.
A GLT2 and a GLP-1.
In the first patient or this patient?
In your patient.
Yeah, we can use. There is no problem. In SGLT2, one has the benefit of particularly decreasing the glucose absorption from the GI tract, not for excreting much of the glucose through the kidneys. That is how basically it acts. But has it come into our practice? Is it available in India as such today? I don't think it is available. The trials are there, but still it is not available to us in our practice. SGLT2 1 and 2 both combined. A lot of trials have happened and still not available for use. But that will be an ideal drug if we have.
I think Canna has got some SGLT1 inhibition, about 10 to 20% SGLT1 inhibition.
Sir, to add to your the current discussion, in India there is no such molecule available, and there is a latest finding which I got, which I come to know with combination of, or rather, the drug which inhibit SGLT1 as well as SGLT2. There is a lot of hypoglycemia. The incidence of hypoglycemia is a little higher with this combination or with this drug having dual action. And another side effect what they are facing is diarrhea, loose motion.
Yeah.
So these are the two challenges, with this SGLT1 and SGLT2 inhibitors combination.
That's what happened initially, because the SGLT2 inhibitors, as Dr. Thomas brought out from the apple bark tree, those days, when they tried it for the patients who had hyperglycemia, they had all diarrhea. That's why this apple bark was not processed further or didn't come into real practice, and it took such a long time to understand these transporters and find a drug which could act on these SGLT2 transporters or SGLT2 inhibitors.
So
SGLT1,
I think,
as you said, can cause diarrhea, can cause hypoglycemia, but the new molecule which has come and a lot of trials have been shown and looks like quite promising in that field.
Let's not be selfish. Let's not take all the questions. I think we've got some questions from the audience. So, what are the renal benefits, I think, of SGLT2? That is what Dr. Suresh from Bangalore is asking. So would you like to take it, Dr. Suryanarayan?
Renal benefits of SGLT2 inhibitors? Yes, there are definitely renal benefits across consistently. All the studies have shown the renal benefits. What are the renal benefits? One is, as the albuminuria is concerned, the reduction in the albuminuria in those patients who have got already albuminuria, or those who do not have albuminuria, at least the renal function, maintaining that, and the decrease in the GFR, eGFR is postponed, means creatinine clearance is better maintained with SGLT2 inhibitors, and even the renal death and all-cause mortality to renal death, that is decreased. And also patients with the renal problem, as all of us know, a lot of them end fatally with a cardiac problem. We know that renal problem, they'll end up with a cardiac problem. That's what happens. And these cardiac deaths, particularly heart failure, and those are also decreased in patients when you give who have got a renal problem. So it's a total benefit as far as the progression of the kidney disease and also reducing the cardiovascular events and the heart failure in patients who have got a renal problem. So that is how it is dual beneficial as far as the kidney problem is concerned. But we should be careful. At least the eGFR is more than 30 when we use this drug. Less than 30, it may not be much of benefit, because although there are studies to suggest even up to 20 eGFR we can give, but in practice, I make it sure more than 30 is always better.
Thank you. Professor Deka, for you, is dapagliflozin and sitagliptin approved as a combination?
I'm not sure, to be honest. I'm sorry. May I just add one point to the renal benefits, because I completely agree with everything that Doctor said before. Just one point. There is an initial dip in eGFR, so this should not be of any concern, because this is the mechanism of mode of action of these drugs.
Absolutely.
We've observed initially a reduction in eGFR. This is because of a lower intraglomerular pressure in the Bowman capsule. So this is how the drugs work. And I apologize, I don't know if dapagliflozin is approved, to be honest.
No, actually it's not approved, but the question was there. And I agree with you, but you know that initial reduction in the intraglomerular pressure, in about 1.5 years, it comes back to normal.
Yes.
If you see it. Yep. The other question I have for you, Professor, is that can you start dapagliflozin in place of metformin as a first-line drug?
Well, that's an excellent question. And I think there's a lot of argument in this way. So the European Society of Cardiology published, together with the diabetes collaboration, that dapagliflozin can be used instead of metformin as the first drug. Now, a lot of people criticize this decision because, for one, we do not have the data. This is the truth, because all these trials were add-on metformin drug trials. Metformin has wonderful benefits and is very protective. So, and it's cheap. So we really have to look at different economic costs. I think there is, again, not really a comparison which one first, but rather a combination. I think the modern diabetes therapy regimen will be a combination of GLP-1 receptor agonist, SGLT2 inhibitor, and metformin. And we are expecting trials as well for metformin to respond. Why this question?
Thank you. Thank you very much. There are two questions from Dr. Zahid in Srinagar. Can you give DAPA twice a day? Yes, you can. Can you give it in pregnancy? No, you cannot. That's very simple. Dr.
DAPA twice a day, is it approved doses? So DAPA...
Yes. 5 milligrams twice a day. You can use it with metformin.
But does it have any additional benefit giving 5 milligrams?
No additional benefit.
Compliance will be poor. Better to give 10 milligrams once a day.
Absolutely.
If you give 5 milligrams, compliance becomes poor.
Yeah. But the theoretical question is that you can give it.
All the trials has evaluated 10 milligram once daily. That's why I'm asking.
But then 5 or 500 and twice a day, a lot of cardiologists are using that dose. The second question is your opinion on the use of SGLT2 inhibitors in type 1 diabetes. Dr. Suryanarayanan.
Yeah. Indiscriminately, without any authorization, it has been used in type 1 diabetes, but we should not use it. It is not approved. As I said, type 1 diabetes is a situation where they need insulin. It is very important to understand. Insulin they need. The SGLT inhibitors have an insulin-independent action. So they may reduce the blood glucose in type 1 diabetic, but it cannot prevent the ketogenesis. So the moment you reduce the blood glucose, the glucagon levels can go high and they may develop diabetic ketoacidosis. So it can precipitate a new glycemic diabetic ketoacidosis. So you should not use. That is what it is, and it is not approved. But some people have tried along with insulin. Some people have done it. It may be helpful to a certain extent, particularly in type 1 diabetics, for obese, who are already on insulin. Without stopping the insulin, with slightly reduction in the dose of insulin, you may, but it is not an approved indication, because those patients who need insulin has to be given insulin. Even in type 2 diabetic patients, if the patient is on insulin and is a diabetes of long-standing, say 15, 20, 25 years, you may add an SGLT inhibitor to reduce the dose of insulin, but do not stop totally insulin. That should be what.
Thank you. Professor Zalnika, this is a question I'd like you to listen carefully to. The usage of dapagliflozin increases the glucose excretion through urination, and it causes a burden on the kidney. Then how is it useful in kidney compromised patients?
Well, so the effect that how SGLT2 inhibitors improve kidney function is first by activating the tuberoglomerular feedback, which means it reduces the intraglomerular pressure. The second thing is it has anti-inflammatory and antioxidant effects on the kidney. And third, it seems that it also reduces the workload of the proximal tubules. So all by this, it reduces the pressure on the kidney, and therefore patients with urinary albumin-creatinine ratio in terms of structural disease and those with lower eGFR benefit from in terms of nephroprotection. Moreover, patients with lower eGFR even derive greater benefits, at least greater absolute benefit, for cardiovascular events. So we shouldn't stop patients with SGLT2 inhibitors in patients with chronic kidney disease. It's just the other way around. These patients are at particularly high risk and should be managed with SGLT2 inhibitors.
Professor Zelnikar and Dr. Suryanarayanan and also Dr. Pandya, can I be the devil's advocate? Suppose the patient's eGFR is less than 30, between 20 and 30. Could I use an SGLT2 inhibitor for benefits other than reduction of A1C?
Other than what, sorry?
Other than reduction in the blood sugar.
Mm-hmm. Well, my point is, I don't think these drugs work very well for reduction of blood sugar in these patients. I think these drugs are cardiovascular drugs. So I would use it. Obviously, I don't know if we have a nephrologist on this panel.
No, unfortunately not.
But so I treat my patients with HFrEF, with diabetes, and with CKD in this time without any hesitation.
Perfect, thank you. Dr. Suryanarayan? Yeah.
Yeah.
Dr. Pandey wanted to say something. Where's he got?
Yeah. So basically, we are practicing in India. If we look at the DCGI approval, so DCGI clearly mentions that we can start SGLT2 inhibitor if the baseline eGFR is more than 45. We may continue it up to eGFR of 30.
Okay.
But after eGFR 30, as per the local guideline, we are supposed to discontinue. Now, if we look at other guidelines, Canadian Society of Cardiology, they approve SGLT2 inhibitor to be used, in fact, to be started at the eGFR of 30. If we look at the trials, some of the Dapagliflozin current trial, they have included patients of eGFR up to 20. Some of the DAPA trials has included patients up
20.
to 25.
Yep.
So actually, if we look at the evidence, there are evidence, but I fully agree with Dr. Zelnikar that probably in this low eGFR, the hypoglycemic effect won't be seen. Rather, it can be used as a medicine for heart failure. And very importantly, it can be used as a medicine for CKD as well, because all the trials has clearly shown both the molecule, EMPA and DAPA, retards the progression of CKD.
Yeah.
Can I add, because I know a little bit about Dapagliflozin. So the latest label of Dapagliflozin says if GFR is less than 25, don't initiate Dapagliflozin. But if the patient is already on Dapagliflozin, please continue the Dapagliflozin, because it provides a lot of benefit in terms of reduction in CKD progression and then other cardiovascular benefit. What they are saying, you may not get A1C reduction or glycemic benefit. Yes, below 25. Yes.
Yeah. Since you're answering this question, Abhijit,
yes.
Can you just say yes or no? Does Dapagliflozin cause bladder cancer?
No, sir.
No. Thank you. And the last question from the audience: can I start for the first time in a hyperglycemic patient? Meaning, can you start it initially, even before metformin? Is the question. I think we've already answered that. Correct?
Yeah.
Yeah. So, Dr. Suryanarayan, any final comments from your side?
I think SGLT inhibitors are very good drugs, and they have increased. As a physician, we can manage diabetes better, but they should be carefully used also. The patient's education, particularly about genital hygiene, is very important, because a lot of them do have developed genital infections and lower urinary tract infections. So genital infections, to overcome that, patient education is important. Particularly in elderly, before you start in SGLT inhibitors, always look at the creatinine and calculate the eGFR. That's very important. And elderly patients, be careful, because some of them do develop giddiness. They may develop a little bit hyponatremia, particularly initial stage. And if they're already on diuretics for a cardiac heart failure, that can cause hypertension and other problems. Elderly patients, be careful. Stop these medications before major surgery, at least 3-4 days. Don't continue during surgery or any acute illness. Stop these drugs and do not start them.
Sure.
That's very important. Don't give them in patients who have type 2 diabetes or patients who are already on insulin. Don't replace this drug for insulin. You can add this drug and you judiciously and definitely give us benefit to the patient. And do not start when EGFR is less than 30. That is what I advise. But if the patient is already on, continue.
Thank you. Thank you very much. Dr. Arindam Pandey, any final comments at all?
So one thing I'd like to say, as I'm a cardiologist, both DAPA and IMPA in the heart failure trials, 50% of the patients were non-diabetic. So nowadays we are using more of these molecule in non-diabetic individual. So in non-diabetic, this definitely comes, before metformin, because there is no role of metformin in a non-diabetic patient, particularly heart failure. So they can definitely be considered as the first molecule, and their role in future is going to, evolve as well. We will see more aspect of this molecule. That's
Thank you. Thank you very much. Professor Thomas, any final comment from your side, sir?
Well, I agree with everything my colleagues just said. It's a very safe drug. It's a very efficacious drug. And perhaps the ultimate comment, which is really nice, is that patients who have hypertension, these are patients where these drugs reduce blood pressure. But patients with HFrEF who have low blood pressure, there's actually very little effect on these patients. So it's really, truly working on the sympathetic nervous system.
Right. Well, thank you very much. Thank you very much, Professor Thomas Zelnicka. And before I wind up and give it over to the people there, when you come to India, there's a standing invitation for dinner.
Thank you very much.
Nice.
It's over to you. I think, Raghavendra, you are going to take it. Thank you.
Thank you, sir. So, good evening, everyone, to one and all who are present here. This is Raghavendra from Alchem Metabolics Division. So, on the behalf of Alchem Metabolics, I feel immense pleasure to take this opportunity to propose vote of thanks. It is such an honor for me to get the opportunity to thank all the medical dignitaries. I extend my gratitude to our international speaker, Professor Dr. Thomas Zelnicka, our moderator, Dr. Behram Pardiwala, and our eminent panelists, Dr. K.M. Suryanarayanan and Dr. Arindam Pandey, for taking out time from your busy schedule and to grace this webinar with extremely relevant address. My deep sense of appreciation and thanks to all 1,200 esteemed delegates who choose to be live with us and attended this Dapanam conclave and made this event very successful. I once again extend my gratitude to all our international speakers, moderator, panelists, as well as all the delegates. Special thanks to Dr. Abhijit Trailokya for providing immense support to make this webinar successful. And I must thank to Team Metabolics for working very hard from past few days to make this webinar successful, because they have gathered all the audience on this event. And I request all the doctors to support with our Dapanom and Dapanom M, which contains Dapagliflozin propanediol monohydrate, which is available all across and every corner of India. Thank you once again for making this great
Thank you and good night. Good night. Good night.
Good night. Good night, Dr.
Bye.
Bye, Dr. Thomas.
Bye. It was a pleasure meeting you. Goodbye.
Good night.
Good night.